Well, thanks. Good morning. It's great to be here. Justin Hohl. I'm from Salt Lake City, so local. We've had an awesome snow year, so you guys timed it perfectly to be out here this year. We've had a ton of snow, and it looks like 6 new inches here at Deer Valley. Snowbird only got 4 inches last night, so we're at the right spot. Anyway, very happy to be here. Grateful for the opportunity to attend the meeting and to present today. And I'm going to talk about post-op accountability and the HA-Peak registry that Innovasis has started. I think this is a great effort, so I'm excited to talk about this. So I'll present just a very quick case. I'll give a quick intro to HA-Peak, what that involves, and then talk a little bit about why registries can be important, and then some of the details of this registry. First, hopefully you don't bump into this guy today. Stay away. This might be like you might have some patients like this in terms of compliance, thinking they can be skiing within a week of their multi-level lumbar fusion. Anyway, quick case. This was a 55-year-old gentleman. This was during my first year of practice. He had severe stenosis and myelopathy. And in a lot of these cases, I'll do an anterior-only procedure and explain to the patient, hey, this may fail. We may have to go back in and do a posterior approach. And that was the case here, and he did indeed fail. He was a little bit of a maniac, but this was actually just 3 months or so after his surgery. So I guess it doesn't even technically count as a non-union, but he started to get this screw backing out at the top level. And I said, let's just keep a close eye on this. And we had periodic x-rays and close follow-up. And then one day he called me, and this was during my boards collection. So this is actually my most interesting case presented boards collection. But he said, Doc, I just coughed up a screw. This little screw came out of my mouth. And so we had to go back and has that happened to anyone else? All right. So last week when I presented this, there were actually like 3 or 4 people that raised their hand that had seen it happen. So that made me feel a little better. Anyway, so we went back and revised him, added posterior. I actually went into the OR with ENT. We used some methylene blue. We couldn't find any communication at that time between the esophagus and the anterior spine. And he did fine. Somehow, we put a feeding tube in. He didn't get an infection, and it all worked out for him. But got lucky on that one. Anyway, this case highlights this issue of non-unions. We all face this issue. Cervical non-unions, lumbar non-unions, certainly with bigger deformity surgery, there's a much higher risk of non-unions. And so one of the questions is, how can we choose an interbody that will help us limit this risk of non-unions? And there are a lot of materials available. We have titanium interbodies. There can be porous or acid etched. There can be PEEK, ceramic, carbon fiber, and then you have HA coated or HA infused. And I'm curious, by a show of hands, who uses a titanium interbody? A few people. Who uses just regular PEEK? Who's been using the HA PEEK? I guess that makes sense at an Innovasis meeting. So it seems like almost the majority are using an HA PEEK. And I've been using that over the past 6 to 12 months, and I've really liked it. So the ideal interbody material will facilitate bone growth. It will allow you to image and determine if there is a non-union. A modulus similar to bone with biomechanical properties similar to bone, and be cost-effective as well. So just a little bit more, some details about what HA-Peak is. So it's a composite material. It's 80% PEEK and 20% hydroxyapatite. But that HA is integrated. It's not just a coating that can shear off or anything, but it's actually mixed in there and fully integrated. So you have the advantages of the structural and mechanical properties of PEEK combined with this osteoconductive property of HA. Again, no coatings or laminate. Hydroxyapatite, just as a little reminder, it's an osteoconductive biomaterial used to enhance bone apposition, and the chemical crystal structure is similar to bone. So some of the benefits that we know about, like I said, it has that bone-like structure. It has an osteoconductive surface. That doesn't work there. And then the radiolucent imaging is another big bonus. When you look at, this is a sheep model. And this is at about 4 weeks, and you can see in just regular peak, these arrows are pointing to these white spots, and those are spots where the bone has not grown right up to the cage. With regular peak, you can often get a fibrous layer at the interface between the bone and the peak cage. And at 4 weeks, when using HA peak, you see at these arrows again, you see that purple and pink, and that's where the bone has grown right up to that cage surface with the HA peak, which is a big advantage. This is one of my favorite cherries of the day. This guy is ready to head out into the snack country. We do a lot of backcountry skiing here. And he has his cheese puffs ready to go. So let's talk a little bit about why a registry is important. I think Innovasis is kind of unique in doing this. I'm sure other companies have registries, but if you think about implementing some type of change in your life, like a silly example, if you are starting a diet, if you weren't monitoring and getting some feedback, it would be like never weighing yourself, never looking in the mirror when you're on a diet. How do you know that this is working? And it's funny that a lot of new technology is introduced, not just in spine, but I think in all of medicine, without a really good way to get feedback. I actually had a rep the other day who told me that when he was trying to kind of sell me on this product, said, well, we don't really need new data because we already know that it works. And we all know that that's just not true. So I really believe in this need to study new technology, and I have a lot of respect for Innovasis in setting up this registry because over time this will allow us to see if to see the benefits, to see pros and cons, adverse events, fusion rates, all the stuff that's so interesting and so important for our patients. So it allows us to help improve outcomes for our patients and helps the whole community. So I'm excited about it. I think it's a great tool. So this HA Peak registry is this quality assessment service that's provided by Innovasis. It's free of charge. And again, it's to further research and overall help our patients in the end. The goals of this registry are to provide a simple, secure, confidential method for data collection and utility. 2, to allow investigators to access this data on a real-time basis, allow us to track these patient-recorded outcomes and the radiographic outcomes, and then aggregate that with our peer data. And then also to provide this resource to assess the data for using in presentations. So the registry includes all of the HA Peak offerings, which include the ALIF, the PLIF, the ACDF, and the TLIF cages. I've used these 3 and have been happy with those. Mostly now I use the ACDF and the TLIF. To go through some of the details here, this is a prospective observational patient outcome registry. We're looking at patients both in the cervical and the lumbar spine with degenerative disc disease, and then in many cases stenosis, spondylolisthesis, radiculopathy. Patients are included. They have to be adults. They have to have an HA Peak device, obviously. Enrolling patients over about a 12-month period, following them for 24 months after the surgery, and looking to enroll over 100 patients, over 10 sites. And the data collection periods, we look at pre-op data, the data at the time of surgery, and then 6-week follow-up, 3, 6, 12, and 24 months. I've enrolled, I think, 12 patients so far. I have a research assistant that does this. It does take a little bit of time. So I think if you're interested in getting involved, thinking about someone in your office, whether it's your medical assistant or if you have a research assistant. Right now, we had a medical assistant in our office who's applying to medical school soon. He was very excited about doing some studies, so he's helping us with some studies and doing a nice job. We have a bunch of other patients that we're hoping to get enrolled soon. I was just chatting with Haley. It sounds like there are about 50 patients so far in the registry. Is that right? And then the patient outcome measures that we're looking at, the CRF, ODI, NDI, VAS, EQ5D, patient satisfaction. A lot of us are probably already collecting a lot of these outcome measures. I've been collecting these for many years, although it's in an unsophisticated way. And so I have paper forms, so my research assistant has been a little bit tortured trying to go through those and match them up. but going forward, we're going to be doing electronically. And then there's this web portal-based these questionnaires, HIPAA protected, although you're not putting any patient info into the registry. You can use it on a desktop or a tablet, and then that's all stored electronically. And then there are notifications for follow-up. It's a pretty smooth system. It works pretty well. These are the outcome measures that are being analyzed. And importantly, these are being analyzed independently. So it's not like we're just reading our own x-rays. We have an independent group reading these for fusion and risks of radiolucency and even alignment and things like that. These are just a couple quick snapshots, some screenshots from the actual process of inputting patients. So when you're adding a patient, this is what it looks like. It works pretty smoothly. Here's just one quick snapshot from the outcomes screen when you're putting the patient reported outcomes. This is how you upload x-rays. This is how you track the x-rays. So you can see which patients are missing data and which data points you need to still fill in. And then here's the assessment schedule. And this is kind of a busy slide and probably a little bit hard to see, but the reason I included this is because you can see the time points here, so pre-op and then all the way up to 24 months. And then you can see, man, I can barely even read this. You probably can't read it at all, but basically the x-ray data here, and then the outcomes assessments all the way down at each of these time points. So I'm going to wrap up there just a little bit early. I went cat skiing last week. This was a huge avalanche. You can see this ridge. I thought I'd just show this to remind everyone to be safe out there. But this whole ridge slid. You can see this huge fracture line. And this snow went down so far, it went up over this hill all the way down. We ended up skiing down kind of right next to that. But it has been an awesome snow year, but a lot of avalanche risks, so just be careful if you're heading out. Anyway, thank you very much.